Good afternoon, everyone who has managed to join this session on building sustainable IPC programs in Zimbabwe, targeting ICAZ members and any other people who are interested in infection prevention and control. Today's session is the 9th of 14 planned sessions to capacitate IPC members. As you saw from the flyer, we will start with Fortunate Mugabe, who is a lab technologist and a student at Bindura University doing the diploma in IPC. He's going to give us the COVID epidemiology and update, followed by Vimbai Msenyereki, who is also a diploma student, and she's a sister in charge at the Pari General Hospital and also IPC focal person. She's a student with Radbourne University. And Chipo Gwagwaya, who is our senior IPC trainer in ICAZ. And today's session is going to focus on repurposing existing facilities in order to develop isolation units, because we, as a country, we do not have money to start new sessions. So to start us off, I'm going to ask Fortunate Mugabe to give us the epidemiology. Thank you very much. Over.
Thank you, Mrs. Mashamba. Good afternoon, everyone.
Good afternoon, Fortunate.
Okay, thank you. Allow me to go through the update. So I'm not going to talk about the definitions because of our time and the uses of public health surveillance. We always talk about this. Let me straightforward go to the update as in the situation at 20 April 2022. As we can see, we are comparing yesterday with the 7th of April. So the new cases were at 47 as per yesterday, comparing to 67. So our cases are going down. And active cases 746, it declined from 946 the last presentation that I did. So the total tests yesterday were 2,211 and cumulatively 2,123,555 with a positivity rate of 1.8% on a 7-day rolling average. And our new recoveries are 10, and cumulatively we have 241,170 recoveries with the rate of 97%. And we had 1 death as per yesterday, comparing with 2 deaths on the 7th. And cumulatively, our death toll has risen to 5,467 with the case fatality rate of the last 7 days at 3.1%. So vaccination for first dose, cumulatively, we are at 5,805,108. For second dose, 3,618,476. And the total number of doses administered to date is 9,423,584. And new admissions, we had 1 admission yesterday, comparing with 0 for the past 2 weeks. So our total admissions is at 20 April 2022, we are at 23 with bed occupants of 0.9%. So on a 7-day rolling average, we see our cases falling to 32 from 35, and the new admissions, we only had 1 with 2 asymptomatic versus 3 the past 2 weeks, and mild to moderate 19 versus 13. There was an increase in mild cases being admitted, and severe cases 2, comparing with 0 and 0 in ICU versus 3. This is good news for us. We have no one in ICU as at yesterday. So of the 23 hospitalized, 14 were vaccinated and 9 were not vaccinated. And now just comparing PCR tests by province, the total is at 2,211 versus 2,625 the past 2 weeks. and 247,000 cumulative cases. Then recovered cases, 241,170. And as for active cases, we are comparing 746 for yesterday, comparing to 1,831. So there's a decrease in number of active cases. And our death toll, we are seeing 5,467 versus 4,455. So we had an increase of about 12. Okay, and then for vaccination, vaccinations, I'm just comparing the new vaccination for 5,566 for the first dose versus 12,813. So there was a decrease in the vaccination of the first dose comparing to 2 weeks ago. And for the second dose, 2,463 as per yesterday, comparing with 2,851. So there was also a decrease in vaccination for second dose. And 2009 comparing to 9,465 for third dose. This was the major decrease in vaccination. And now, if we are to compare the resurgence threshold by province based on new cases, as at 20 April 2022, we realized that only one province, which is Bulawayo, the 20% above the increase in new confirmed case. So it's likely to be in a resurgence. And for the tests done, really, we can see that this time we have 3 provinces which are in red, doing less than 5 tests per 10,000 population. So this is this shows that it's because that we do not have COVID these days. It shows that our testing has also gone down. Okay, let's move ahead. So percentage change for new change. If we can check on the last 7 days, we can see that 223 new cases and 7 deaths with case fatality rate of 3.1%. Then no province reported an increase in the number of new cases, and there was a 38% decrease in the number of new cases reported. So this is good news for us. We have decreased in COVID cases, so the graph is going down. And now in the last 7 days, if we check the percentage change for tests conducted, we will realize that Masvingo had the largest increase in tests done, while Matabeleland South had the largest decrease of percentage of tests done. And the number of tests done decreased by 17.6. And this can be explained. We see there's a 4 in cases. So whenever we have a decrease in our cases, we realize that even our testing goes down because people will not be willing to be tested because they have no symptoms. This is just an EPICF to show us that the number of cases are decreasing. If we can check, you realize that when schools were opened with this increase, and you can see that the increase happened during schools open, and now there's a decrease in number of cases. And so lastly, if I am to talk about the summary, we can say in summary, no province reported an increase in the number of new cases in the past 7 days, and the average positivity rate is at 1.8%. This is the take-home message. If you didn't catch everything that I was talking about in all the slides, this is just a summary. And all provinces have less than 12 active cases per 100,000 population. All provinces is a doubling time of more than 1,920 days. And in the last 7 days, the number of new cases reported decreased by 38%, and the number of tests done decreased by 17.6%. And our bed occupancy still is at 0.9%. And in the last 2 weeks, provinces with the highest case fatality rate were Masvingo with 14.3% and Mashonaland Central at 10%. So Zimbabwe so far administered 2 doses to more than 3.6 million people. I can say this is the summary, and I say thank you and over. Thank you, Mema Shamba. You can go ahead.
Thank you very much, Fortunate. That shows that as a country, we've been lucky so far, but let's not be complacent. COVID is still with us. If you see the resurgence in countries like China, in the UK and the other countries. So let's not let down our guards and continue to be, we continue to conduct screening and triaging as we discussed last week. So thank you very much for the good news. But with schools reopening and rallies, we should be on the alert as always, and encourage people to continue screening and triaging. Now we'll have Vimbai to take us through how they repurposed their awards at Pari. Thank you very much, Vimbai. Over to you.
Thank you, Mema Shamba. Good afternoon, everyone. I'm going to take you through the case presentation. My name is Sister Vimbai Nashim Senyareki, and the organization I'm talking about is Paranyatwa Group of Hospitals. Right. So my problem statement is highlighted by Ms. Mashamba is the IPC considerations in setting up a COVID-19 unit in a quaternary healthcare institution. This is the case of Paranyatwa Group of Hospitals. So Paranyatwa is
sorry to disturb. Your presentation is not moving. We are on the first slide.
You are still on the first slide.
Yeah, if you can put it in the presentation mode and then try.
Okay, let me try again. Maybe let me stop share and start again. All right. Let me start. Is it moved now?
Yes, you are on the challenges slide. If you can just move.
It has moved.
Yeah.
Okay, so that I see if it's going to move again.
Yeah,
is it moving?
It's moving, yes.
All right, so it's fine. Thank you for that. All right, so Paranyatwa Group of Hospital is an acute care hospital which comprises of about 4 main hospitals, which is the main hospital, which offers essential services. Then we've got the maternity hospital, we've got the eye clinic, and then the psychiatric unit. So the whole hospital is a 1,200 bedded hospital that has been an average bed occupancy of 80 to 90%. So all critical and essential wards are usually full to capacity, and empty space is spread amongst the wards that cannot be combined. And for this reason, there was need to identify an appropriate section which was separate from the main hospital into an isolation unit. So when I say all critical and essential wards are usually full to capacity, it means we might have a burns unit, we might have an oncology unit, we might have a medical ward. So as much as they might have the 10% empty space, we could not put the wards together in order for us to combine wards and create an isolation unit. So the tasks that were involved in trying to come up with the isolation center, we needed to identify an appropriate section of the hospital that would allow for isolated cases in terms of where we are going to have a separate flow of staff, flow of the patients that were coming in, so that they don't mix up and there won't be any challenges with mixing up with different types of patients. And also in all this, we needed to ensure that we were not going to put the rest of the facility at risk of SARS-CoV-2 infection. The other task that was there was ensuring that the isolation units that we were going to identify would be able to deliver oxygen, because I'm sure we are all aware during the first or the peak of the COVID disease, oxygen was the #1 drug, and we needed to ensure that the facilities that we were going to come up with will be able to deliver piped oxygen. And we were also going to be able to give intensive care unit or high dependency care for the patients that we were going to admit. So also ensuring that in us incorporating the isolation units, remember we said we're already a quaternary hospital, which is an acute hospital. and already was full to capacity, we needed to ensure that there is going to be a continuity of delivery of other essential services to the rest of the hospital. So the actions that were taken, first, there was an identification of a COVID-19 task force, which comprised of clinicians and engineer and architect and IPC focal person, and also support from Infection Control Association of Zimbabwe. So the clinicians involved the clinical director, physicians, and anesthetists. And then what we did a situation analysis where we went throughout the whole hospital. We made weekly meetings and visited around the hospital so that we identify the places that we needed to do. We just didn't sit in a meeting and decide, oh, we're going to take that one. We had to go on physical site visits. So we identified isolated hospital, which was the eye hospital and maternity hospital. But for reasons of piped oxygen and flow of patients and staff, that was going to be compromised. We could not utilize these isolated facilities because we did drills and it was not possible. So with each of these identified task force members, we ended up with an agreement that we needed to, we needed to demarcate the main hospital into two, where the southern wing was going to be separated from the northern wing, and there was a seal in between that would not allow free movement of staff or patients. And then the southern wing was then identified to be ideal for the isolation unit. Because there was going to be piped oxygen and there was going to be a clear flow of staff and patients. And then this identified isolated wing had a capacity of 450 beds, 2 theaters, 27 ICU beds, and 4 renal beds, which were for dialysis. We were taking into considerations what the clinicians needed on the ground, because this clinician we're talking about were challenges with some patients outside who couldn't go for theater, some who couldn't go for dialysis. So we were taking all this into consideration when we're coming up with the isolation unit. So the best practices that we managed to gather, or that made it possible for us to identify this isolation unit, was teamwork, as every side had an important input, and every input was considered to make it work. And then we ended up writing clear, written standard operating procedures that were specific and straight to the point, so that it would guide those on the ground and those who were supposed to end up doing the management of patients. So these were clear IPC protocols that were specific to the isolation unit. The donning area, which was the PPE policy, what you needed to put on, where you needed to put it on, what we were going to do with the doffing area, how we were going to clean the environment, how patients or staff were going to move, hand hygiene, things that needed to be in place, and also training of staff. Everyone was going to work in the isolation unit, whether they're coming from a different ward or different place. If they were now going to come in the isolation units, they needed to be trained and orientated on the movement of staff and everything that was in the isolation unit. Then decontamination of equipment, management of linen, and anything else that was deemed necessary to this new identified isolation. So there was also identification of team leaders to maintain and help carry out implementation of the expected SOPs. Remember, people were coming from different places and now it's a different area. So we needed the team leaders to be in place so that we carry out and then we maintain flow of patients, flow of staff. And then continuous support and active presence of the IPC team was always on stand 24/7 whenever there was need to give input, to give advice, to give training, to do drills. And ability to adjust accordingly was one of the major things that really helped make this isolation unit a success. Because when we needed to expand, suppose we were utilizing 2 or 3 wards, if there was need for us to expand to 4 more wards or to 10 more wards, we wouldn't say this is an isolation unit that is specific for that. We had an expansion plan of which ward are we going to take in next, which ward are we going to take in after this one is full. We also had a reduction plan where the waves were going down so that we know that fine, we are utilizing 5 wards. Now we need to tone down to 1 more ward. So how are we going to do it? We are going to first give off this B ward, then we're going to give off the next ward until we are left with 1 ward, and we could then go to a different isolated facility. So as much as the isolation unit was 450 beds, when we were occupying 200 beds, it meant the other 200 could be used for other essential services and would have a proper expansion or reduction plan. And also this code for continuous update of policies and standard operating procedures, so that whenever things were changing, even in our isolation facilities, we would adjust them accordingly. At first, we needed a specific donning area for everyone and a specific doffing area for all the wards. And when we needed to adjust to make sure that per each ward, there's a donning and doffing area, we ended up adjusting accordingly, so that at least we move with time, and we adjusted when we saw that things were not really moving appropriately with the first given policies that were in place. And then we can never underestimate the support that we received from management that was always ready to adopt and accept everything that was needed to be put in place. So I heard that we are not going to do any discussions, maybe just questions for us to ponder. If we, maybe for next time, or if you're going to write in the chat box, or even wherever you are, maybe just looking at the challenges that you faced when you were identifying an isolation place in your institution. Was it easy to put words together, group everyone together? And what prompted the choice you finally settled for? Remember, we also identified that we had initially identified isolated wards, isolated hospitals. They were the first choice because they were far and away from the main hospital, but we could not utilize them for specific reasons. The other one, there was no piped oxygen. It was going to compromise movement of staff. But I know the majority of areas chose an isolated facility by the fact that it was far away from everyone else. But everything else put into consideration, we're not sure. Then if you could have done things differently in how you have set up your isolation facility, or maybe even how we set up our isolation facility, could you have done them? And what would you have done? And have you also made the necessary, have you made plans to make the necessary changes? Suppose another coming wave is coming, or outbreak, because this is the child, when usually the wave is down, people settle down and they wait to start panicking until another wave comes in. But this is where we found our strength, where we had the reduction or expansion plan, and we are always ready to move accordingly. And any recommendations to facilities on how they can set up their isolation centers at their facilities. With that, that is the end of my presentation. Thank you. I hope I managed, Chamba. Thank you so much.
I know, Vimbai, thank you very much for racing us through, but capturing the issues that made your isolation center a success, especially being the major country's referral hospital. At the beginning of the pandemic, we're anticipating quite a lot of cases, and they did okay in the third and fourth wave. But as you heard from Vimbai, they were moving with the pandemic and also following guidelines. For those of you, after the policy change where ministry said all district hospitals and provincial hospitals should have an isolation center, that helped decongest Pari. But I know some people were struggling in ensuring that the isolation units that they are repurposing were purpose-made to prevent infections. So thank you very much, Vimbai, for the lessons that you gave us from Pari. Now we are going to have Chipo Gwayagwaya giving us some tips and advice on how we can repurpose our existing units in line with what Pari did and what other people are doing in order to prevent infection of other patients within the hospital. Thank you very much, Vimbai. Now we'll have Chipo taking us through how to repurpose an existing ward. What considerations should we have? Whom should we involve? and how can we ensure that staff are protected from getting COVID while they're nursing patients with COVID. Over to you, Chipo. Thank you, Vimbai.
Afternoon, everyone. Thank you, Ms. Mashamba. Let me share my screen. All right. So I'm going to talk about the layout and flow in specialized units, the ideal, and how to move to get it right. I'm sorry, my slides are not moving. Hello, Mumbai, are you still sharing?
Have you put on slideshow?
Can you stop sharing?
Okay, let me see.
Okay.
All right, I'm no longer sharing.
All right, let me just try to find out if I can move my slides. They are not moving. Tabeth or Alina, can you help me out? Let me see. All right. So as my...
Chipo, I have shared my screen, so you can let me
right.
know and I'll change the slide.
Yes, next slide too. All right. So the objective of this presentation is to define specialized units, to describe the layout of specialized areas, to describe IPC consideration, and explain the flow of staff and patients. Next slide, Alina. So various specialty care areas exist in many healthcare facilities, and these include adult and pediatric ICUs, theaters and surgical wards, oncology departments, and infectious disease units. So specialized care units are purpose-built, and layout is organized to minimize risk of infections to patients, healthcare workers, and visitors. Work practices and processes are also tailored to enforce key IPC principles in order to protect patients, staff, and visitors. Next slide. So our specialized units, what is a specialized unit? A specialized unit is a unit with specialized equipment, medical and nursing staff, which are also specialized to work in that unit. They are designed in a specialized manner, mainly considering healthcare workers and patient safety. For example, intensive care units, maternity, our renal unity, and infectious disease unity. That is what we are calling now isolation units. Next slide, Alina. So the layout of different departments, units, or wards in relation to each other will determine how staff and patient move within the facility, and number of patients and type of equipment that can be accommodated. So when we had the pandemic COVID, some of our facilities, they were not suitable for being infectious or isolation units, because our hospitals were not built with isolation units. And we were just aware that when we have got infectious patients, each hospital, being it private or public, they were sending their patients to the designated infectious hospitals. That is our Wilkins and our BRIDH in Harare, and in Mutare, Gweru, Lawayo, they also have designated infectious disease hospitals. But with COVID, number of cases were so much high, so each hospital was asked to have its own isolation unit to accommodate the community where the patients will be coming from. So when building or repurposing, engineering and administration controls needs to be well established in order to have effective implementation of IPC measures. Next slide, Alina. So these involve how the actual healthcare activities, that is the work process, are normally conducted. The administrative controls should lead to work policies or procedures that are aimed at reducing or minimize exposure to a hazard. Like what Wimbai said, what was important in their repurposing policies were important, and the standard operating procedures were so very important. Administrative controls, examples of COVID-19 were updating training of healthcare workers on COVID-19 risk factors and protective behaviors. For example, hand hygiene, the rationale of use of PPE, donning and doffing of PPE. So of late, this was not really taken seriously. Only in the infectious disease hospitals, that's where they used to practice this, but not seriously. But with COVID pandemic, this was reinforced, and each and everyone should know how to don and doff PPE, how to hand wash properly, the steps of hand hygiene, and what to use to do the hand hygiene. So establishing screening and triaging points for all stakeholders was also important, and is also important when you're laying out or repurposing facilities. I understand that last week we were talking about screening and triaging. Enforcing safe behaviors, that's the standard precaution, and having reminders in the workplace. For example, the IEC materials to remind us of the COVID pandemic is also important, or any infectious diseases which will be going on at that moment. So having psychological support to address healthcare workers' anxiety or stress factors is also important, because healthcare workers' psychological and social needs should also be attended to. Providing enhanced medical monitoring of medical workers during the outbreak. It's one of the last of the administrative controls which you need to consider when repurposing or building isolation centers or specialized units for infectious diseases. Next slide. So the engineering controls to be considered. This focuses mainly on the infrastructure, the layout of different department units, wards in relation to each other, determines how staff, patients, and other service providers, for example, waste removal, food services, move within the facility. You can't have the same doorway people are entering, it's the same doorway, the waste is also being temporarily kept, and you are also taking it out through that door. So you need to know the flows and how people and other services are moving within that facility. The number of patients and type of equipment that can be accommodated. So since it's infectious disease, social distance does not only happen to the people who are in the community, it also happens in patients who are in the ward. So you need to know the space in which you want to use and the bed space between each patient, and the type of equipment, as we heard about the oxygen, which Wimbai was saying with the first unit they identified, there was no oxygen. So all those things are considered. Availability of sufficient and hand hygiene stations, both for hand washing or sanitizing by patient, staff, and visitors. Ventilation systems, whether mechanical or natural, all these have to be considered. Next slide. So our isolation units are built on disease burden of infectious disease in that country. For COVID-19 pandemic, existing facilities have been repurposed to become isolation facilities, and new structures that temporal or permanent have been established to facilitate triaging of suspected and confirmed cases of COVID-19. Next slide. So the IPC for consideration for repurposing or building, when building or renovating, you have to consider space for the following: clinical space, hand hygiene facilities in the patient care areas, reprocessing of medical devices, like what Wimbai was telling us about decontamination and sterilization, kitchens, waste management, all those things have to be considered. Staff areas where they will eat, they will rest in their conference rooms, including separate space for ancillary staff, clean and dirty areas, medicine preparation, the sluice room, waste holding areas. All these needs to be considered. Next slide. Next slide, Alina. Continue with the IPC consideration. Also need to consider good ventilation of 12 to 15 air changes per hour. And this is not achieved naturally. You need to have mechanical ventilation so that you really achieve the 12 to 15 air changes per hour. The type of floors, lighting and other furnishings within the isolation unit. The patient's comfort is also considered. Separate toilets for staff and patients, isolation areas, single room or cohort facilities with insert facilities, storage for PPE, sterile items, drugs, and etc. etc. Next slide. So moving from what we have to where we need to be. So this is what now, from what we have, we had our wards, our hospitals without infectious units. So now we need now to repurpose them so that we have an isolation unit in the facility. When we are no longer saying we are sending our patients to BRIDH or to Wilkins in Harare, because those facilities will be already full. And within the hospital, other patients would turn positive to the infectious disease, which is being talked about. So like COVID-19, whilst you have your patients in the green zone, there they will become positive. What do you do? Wilkins and BRIDH is full. So it was very much ideal for every hospital to repurpose so that they will have an isolation unit of their own. Next slide, Alina. So involvement of IPC practitioners is very, very important because existing facilities have been repurposed to become isolation facilities and new ones established to manage COVID-19 patients. It is important to actively involve IPC practitioners or experts when constructing, repurposing, or renovating healthcare facilities in order to make sure that the infrastructure will support good IPC practices. Next slide. So example of a unit before repurposing. This is normal to us. This is what our wards were looking like. And this is an example of a normal ward before repurposing. Next slide. Next slide. So this is one of an example of repurposed unit layout and design of an isolation unit. When now people were trying to repurpose now. We need a donning and doffing area. The donning and doffing should not be at the same site. And when we are donning, we need toilets for the staff. We need a sluice room. We need storage area. We need entrance for the staff and different entrance for the patients. And we also need restrooms for staff and all that stuff. So let's see what is ideal now. Next slide, Alina. Ideal layout of an isolation room now, it looks like this, where we have a male toilet and a female toilet and a donning area. We have a staff entrance, PPE storage area, a storeroom for other things, a pharmacy within the isolation area, a sluice room, entrance for patients exit, and then where the patients will be accommodated. We should have a nursing station within that area, and we should have other, this is just an example, we should have other services, the kitchen, the laundry, all that should be in this ideal layout. So the donning and doffing, the showers and the change rooms for staff, and the way the staff would exit. So basically, this is how in an isolation unit or a repurposed area should look like. So most of our repurposed facilities are looking like this, more like it, but yeah, only Parenya Twa is got the ideal, and they have managed to repurpose to this, but some are still struggling. They are still in the process of repurposing. They haven't finished. And I was going around last week. I went to Marondera Hospital. They are almost there, and they also have mechanical ventilation in their ward. And yeah, they are good to go, and they are admitting patients in their isolation unit. Next slide. So you should know the staff and the patient flow within these units. The movement of staff and patient in an isolation and treatment facility should be controlled, and it should be unidirectional. So we have our low risk zone, where we should call our green zone. That's our nurses stations and our jute rooms. They are low risk areas. The intermediate areas are the yellow zone. And this is our areas where these suspected cases will be kept and will say awaiting results. Then we have our highest risk zones now, where we have the patients with real disease who have been confirmed to have the disease. So staff areas are low risk areas, and direct movement from high risk areas is prohibited. And our doffing areas are separated from the donning areas. Next slide. So in summary, what are we saying? We are saying we have to involve IPC practitioners before layout, design, and or repurposing space for any specialized units. Repurposing and ensuring areas conform to IPC standards is possible in low middle income countries and low middle income settings like what we have in our country in Zimbabwe. We are a low middle income country. We are not yet a, what do you call it, middle income country. We are still low. So what we have discussed is what we can do to make sure that we repurpose our facilities without risk of infections to the patients, to the healthcare workers, and to other stakeholders who visit the facility. Next slide. With that, I say thank you for listening to the presentation. And yeah, we still have 15 minutes. Over to you, Ms. Mashamba. Thank you very much for allowing me to present.
Thank you very much, Chipo, for that presentation that demonstrated that you don't have to be a high-income country or a quaternary unit in order to protect patients and staff. Because like you rightfully say, some people at the tail end of the pandemic, current pandemic, they are still struggling with repurposing their units. Because one of the things we realized was we have a Ministry of Construction with the engineers. Some of those engineers are not trained in IPC. So there is need for trained IPC practitioners to be part of that group or team that looks at what you have and how you can adapt it, like the example we had from Vimbai. So thank you very much for pointing that out, because the IPC practitioners, some of them who are not proactive will say, I was not involved, they left me out. You don't have to be left out. You push yourself in because you are helping the unit. And we have also said, if you are having any problems, contact the trained and knowledgeable IPC practitioners like at Pari, at some of the private hospitals that we helped set up their units, including ourselves as a team. Because we have to work with what we have. Tinoshanda nezvatinazvo. don't just sit back and expect a construction engineer to do it by themselves. The management rely on you as IPC practitioners to guide them. So we had some units that sealed the windows in order to contain the SARS-CoV-2, in the process infecting staff and other patients. We also had some nurses stations right in the middle of the ward that is nursing patients. But so thank you, Chipo and Vimbai, for demonstrating that when you do repurpose, you have to consider the engineering, environmental, and other considerations that prevent transmission of infections. So let's look at the chat box and see if there are any questions, or by raising your hands, you can ask questions, especially those of you from districts that were struggling to get the right repurposing structures in place. Let me just quickly look at the chat box and see. By show of hands, you can raise your hand if you have any questions. We have some time for a few questions. I see Beulah Kujanga's hand. Beulah, come through. Do you have a question?
Good afternoon.
Unmute yourself. Yes, thank you.
How are you? I'm
Fine,
very
thank
happy. I'm very happy to be part of this training today. It's very important that Chipo pointed out about the involvement of IPC practitioners. You find that as we are in the periphery, in the districts, most of our district institutions do not have any, even a single room isolation, which is prepared for any eventuality if we are going to have a patient. So the issue of involvement of these public work guys is very important. I think the first and foremost thing we need to do is to advocate for their training. We train them so that they understand what we mean when we say we need to repurpose a building, because they feel that the buildings are theirs and we have nothing to do on those buildings. But it's very important because of this, these emerging infections. We need to work together as a team. So it's very important for them to be involved. And I want also to thank Chipo for this very beautiful presentation. I thank you.
Thank you for that comment, Beulah, because I think we will share this presentation because grammatically, if you have a donor, like we saw in one of the hospitals, I think it's Shurugwi Hospital, if I may, this is a forum where we can help each other repurpose. Where you have a funder who wants to help you, you are the specialist, you have to point them in the right direction. So if you have these diagrams, they will help. So let's have, thank you, Chipo and Beulah. Let's have Buiswa. Bui, you have your hand up.
Thank you, Ms. Mashamba. And mine is not a question, but a comment directed to Vimbai and Chipo. Thank you so much for the detailed presentations. And what I appreciated from especially Vimbai's presentation is the fact that they formed a multidisciplinary team that came up to actually act on the ground. They didn't wait to start putting cement and bricks so that they build a new place, because that is one of the challenges that we've been having probably in the country, whereby even up to today, there are some facilities that are still being having isolation units constructed. But with what Vimbai and the team did in Pari, getting to make the patients safe, and also the healthcare workers by critically assessing the space that was available and trying to make proper use for it. It's really a good lesson learned, which I think can be cascaded even to the lower level facilities. Thank you, and over.
Thank you for that comment, Bui. The other hand we have is Bimbai's. Bimbai, come through.
Thank you, Ms. Mashamba. I think my question is a person who ran through their presentation, and I hadn't managed to ask the meeting for their response. If I think it would really work out for all of us. Maybe if there are people who've got anything to say, maybe lessons learned from when they were repurposing or rebuilding their facilities. I just want to know if there are people who know, fine, we did it this way, but we could have done it differently. How is it, do you know what you did best and what you're going to do again the same time if we're going to be faced with a different pandemic? It could be COVID, it could be cholera, it could be anything that is going to come in the next few years. Is there anything that you say, yes, we did this correctly and we're going to do it again? Or is there something that you as a facility, or even you as an IPC practitioner, you've identified we messed up, or we didn't do it so correctly here? And I think if we were given a chance, we're going to do it differently next time. Have we managed to think that through? Maybe it could be a question to take home, or it could be something that you already have at hand and you want to give us on the platform. Thank you.
Thank you for raising that, Vimbai, because from my experience, some people have closed their units, their cobwebs, and they've put away all the equipment. And if they get a case today, they'll start running around like headless chicken to put things in place. Let's have the last comment or Patience, what you could have done better or what you've learned from this presentation. Over, Patience. Patience Ndlovu.
Hello.
Hi, we can hear you now.
Oh, good afternoon, everybody.
Hi, Patience.
Thank you so much for the presentations. I think they are really important. And I would like to say that Vimbai's question is quite pertinent and we shouldn't really ignore it, because I had the privilege to be called to try and repurpose, but we had a lot of challenges. It's really, I think we need maybe policies that can assist the IPC focal persons on the ground, because you find that when you're now on the ground, despite your technical advice, people still do things that are against what has been said or advised or proven. So I think there are areas where I think there's, as the IPC pillar, maybe since we're reviewing policy and stuff, we really need to put it down and make it clear. For example, they would ask about finishings, and then you suggest the kind of finishing that is important. And then when it's being bought, after all the quotations and all, you find that now there is the ceramic tile in a ward, or you find them saying, as we were buying, it was expensive here and there, this and that. But the other lesson that I learned was that with the built environment, you really need partners to assist. Even if you are repurposing a ward, you still need the finances, because we have other repurposed buildings like our Mapisa Hospital that is still not complete, though it was not built from scratch. So I think there's still more to be done, and to recognize that the IPC practitioner really needs to play a role and be accepted when we are doing the infrastructure issues. Thank you.
Thank you very much for sharing that, Patience. It's very important. I see Dr. Dege, you have your hand up. Celestine, Can you share your experience or give your comments?
Hello,
Hi, Dr. Dege.
you can hear me.
Yes, we can.
Thank you very much. About 2 weeks ago, I had the opportunity of joining a team that was going to Zambia, headed by the Deputy Minister of Health and Childcare. And we were going to look at the plans of 60-bedded hospitals that are going to be constructed here, using a different type of model in terms of construction. It was critical, and I'm really happy that I was also available to contribute to the plans. There were quite a number of changes we had to make in terms of theaters, in terms of the CSSD, even in terms of our maternity wings, so that we improve in terms of IPC. So really, I felt it was so important that even by the time the architect actually complete the plans, you have already inputted into that plan, so that the product that you have already is designed with the issues of IPC taken on board. So I would hope and wish, because the engineers were there, architects were also them. So we had to agree on what we wanted to see considered in terms of IPC for those units. Even we created some isolation wards in each of the units that will be there. And we made sure that IPC issues were actually considered and taken on board. So I'm hoping that going forward, such activities always take into consideration the IPC input at the planning stage, at actually the drawing of the plans themselves, and then continue to be part and parcel even during the construction of the units as well. I just thought I would share that sort of experience and exposure that I got. Thank you.
Thank you, Dr. Dege. That was very useful because like you rightfully say, IPC focal persons to be involved right from the start, during, and at the end when you are commissioning it. Because what patient said is you may recommend a seamless flow, and then lo and behold, you go back and you find they've put tiles, nice slippery tiles that, and yet the money was there, just because the buyers did not involve IPC. So IPC should keep an eye weekly, like Vimbai was saying, when they go around, even if it means them, the constructors, removing the inappropriate material to make sure that the unit is purpose-built, especially where you have the money. So you yourselves as IPC practitioners need to be knowledgeable. If you are in doubt, let's support each other and consult each other. So I would like to thank everyone for their input. I think this will be, going forward, this will be useful for those whose units are still at different stages of construction. If you look at those diagrams, those can help you. And if you are in doubt, contact any of the people that have done it before. I think with that, I want to thank all the presenters for very useful presentations. And I would like to also thank the participants. We had 21 today who also gave very useful comments. I think we should continue capacitating each other, and remember, COVID is here to stay, or other infectious diseases. So we have to learn to be prepared at all times and move with the pandemic. Thank you very much for everyone's input. Unfortunately, today we won't have time for more, but if you have any questions, just post them in the group. We will try to answer them. Thank you, everyone. Thank you, Alina and team. Thank you, all participants and presenters. over because we have to go into another meeting just now.
Thank you,
Thank you,
Leta.
ma'am.
Bye bye.
Thank you and bye. Thank you, bye.
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 Thank you.